Yeah. Oh.
Okay, good morning, everyone. We're gonna get started here with our neurosurgery grand rounds. It is my pleasure this morning to introduce Dr. Arushi Bhargava. She's an assistant professor in biomedical engineering here at the university. I first met her. I went to a meeting in Canada on therapeutic ultrasound, and she was literally like the second person I met when I arrived there, just randomly, which was odd because she works right here. But we of course, taking this opportunity to kind of find collaborations. She and I have been talking a lot about therapeutic ultrasound applications, and I think what I'm really hoping to get out of this talk for everybody here is just kind of what the opportunities are in neurosurgery. In the brain specifically, although I think there's many more applications than that. Arushi did her postdoctoral fellowship at the Max Planck Institute in Stuttgart. She was a postdoctoral scholar in the Department of Radiology at the University of Chicago, and then earned her PhD at Virginia Tech. So she's a very well trained, great person, great person to work with, and so I'm very excited to hear what she has to say. Thank you.
Great. Thank you so much, Natalia, for the introduction. And I'm glad for this opportunity to come and talk to you about therapeutic ultrasound. I mean, I will try to keep it short, but I can go on and on about this topic. But our main intention, like Nathaniel mentioned, is to give you an idea of what therapeutic ultrasound is, how it works, what are the potential applications of it, both emerging and FDA approved, and then help you develop that understanding where you can probably find now more creative solutions to use this tool in your own research or in your own application. So yeah, now I will start with very brief introduction of what kind of ultrasound I am using or we use in therapeutic ultrasound. You guys can see, right? Okay. So ultrasound, typically the frequency range that you guys might be used to is the diagnostic range of ultrasound, which is 10 megahertz, where you can use it for imaging tissues and things inside the body. But therapeutic ultrasound, when we use it for therapy, is slightly different frequencies. We typically use less than 5 megahertz of frequencies, and when it comes to brain, we even use lesser frequencies, typically around 200 kilohertz to 500 kilohertz in the brain. And the way that we use therapeutic ultrasound is by focusing the energy of ultrasound, which is coming from a source, into this very tight focal spot. Okay? And the way the pressure variation happens in this focal spot is that as you go from this point to this point, the pressure will be, the most of the intensity will be focused in this thing called focal region, which is like few millimeters wide in this direction and few hundreds of micrometers wide in other transverse direction, which forms your focal volume and which is the treatment zone. Anything around this focal zone, as you can see, the pressures are pretty low. So this means that when we are targeting using ultrasound, we are only focusing at that tight spot, and everything else is it's not probably, but it's safe from any kind of side effects. So this is the intention here. Now, focused ultrasound can be used for generating.
Yeah, I guess you were going to get to it, but I'm just saying that sound energy is a mechanical, correct?
Yes, yes. So depending. So here we are looking at focused ultrasound and two kinds of bio effects that it creates. It can create a thermal energy bioeffect, which means it can cause a rise in the tissue temperature, yielding to necrosis. And then the second type of effect is depositing mechanical energy, and a lot of portion of this talk is focused on mechanical energy, but I also wanted to introduce this thermal energy because it has been the more traditional kind of ultrasound therapy so far. When it comes to thermal energy and how it can be used for treatment purposes, particularly in brain, these are the various applications right now already either in clinical trial or they are in FDA approved, where the energy is causing some temperature rise, usually causing irreversible thermal changes in the spot that is being targeted. Okay, so however, and a lot of it is actually can be tracked through imaging also. So particularly with the thermal effects, I wanted to emphasize that a lot of therapy is done with MR guided image therapy. So there are where we have transducers that are compatible with an MRI machine, and where the patient is brought in while they are being treated with ultrasound, and the temperature mapping is done through MR. Okay. Again, so I told you about the thermal effects. However, ultrasound can also be used to generate mechanical effects. And now mechanical effects fall traditionally into three categories, which I will tell you later. But just wanted to show you all the applications that are possible with these kind of mechanical effects. None of them is FDA approved right now in the brain. However, a lot of them are in clinical trials. Now, when we come to mechanisms of how ultrasound can deposit mechanical energy, there are three main mechanisms. One is radiation force. The other two are stable and inertial cavitation. And I will be just talking about each of these mechanisms and how they are being used for treating a lot of different conditions. So I don't know if you can see this video here. Yeah. So this is a video. Are you able to see this video? Okay. So this here is an ultrasound transducer, and what it is doing is it is sending ultrasound waves which are kind of pushing this particle away. So this is one mechanism of ultrasound waves that we can use, which is called radiation force. We can use it to apply force on any object. And typically, this is being used for neuromodulation, where gentle forces are applied on neurons. Now, the conditions that are being targeted in clinical trials with neuromodulation are these and these. Mechanotransduction is just one of them, where we apply, where ultrasound waves can actually activate some of the mechanosensitive channels like piezo1 and cause an influx of calcium. So these are all these conditions which just use these ultrasound waves and the gentle nudging power from that to stimulate cells. Okay. The next mechanism where ultrasound comes in, again through mechanical energy, is called stable cavitation. Stable cavitation means that we are using low intensity of ultrasound waves, and under these waves, whatever bubbles that are present in a medium, they will show gentle oscillation. They will compress, expand, compress, expand. This is a stable periodic motion that these bubbles can do. And if you're wondering what these bubbles are typically the contrast agents that clinicians use. So one of the contrast agents that is approved, FDA approved, is definitely, I'm not sure if any one of you have used this, but it is this version and any other version that we usually use is just a lipid shell filled with a gas core. And this gas core is the key mechanism which helps us to see these bubbles under ultrasound and in fact make them oscillate as well under ultrasound. Okay. And the
physics of this ultrasound versus the thermal ultrasound, different wavelength, different frequency, what's
very different. So we generally use slightly higher frequencies, and we use so the question here is that what is the difference between the acoustic conditions to generate thermal effects versus mechanical effects? Thermal effects are usually done over time. So that means the temperature evolution that is happening happens over seconds and minutes altogether, so that enough heat is accumulated in the tissue to cause necrosis. However, for mechanical effects, we are using extremely short, ranging from microseconds to milliseconds of pulsing sequences. And that's why the heat accumulation is minimal under these conditions. The frequency range is also different depending on what kind of tissue you are targeting, particularly for brain. You cannot use higher frequencies because of the skull. However, most likely we will be using higher pressures to generate thermal effects as compared to let's say this stable cavitation.
And can you just comment on how the frequency affects how far the depth where you can work?
Yes. So the thing,
maybe simplifying it.
Yes. So the skull has attenuation effects, which means the higher the frequency that you'll use in the skull, it will have more of attenuation and more of random reflections happening in the skull. However, even with these frequencies, we can go much deeper than the traditional imaging mechanisms. If I'm using something like 500 kilohertz, then I will be looking at a depth of at least 5 to 6 centimeters inside. But there is a game that needs to be played with the kind of parameters that you want to operate at, just to avoid any kind of attenuation and heating effects. However, yes, the depth is, ultrasound has maximum depth, 5-6 centimeter is pretty straightforward. Okay, so I was discussing about stable cavitation. Any other questions at this point? Okay. So yeah, so these are the kind of bubbles that we typically use to cause stable cavitation. Now, one of the prime things that you may have observed with stable cavitation or with this kind of bubble activity is blood-brain barrier opening. So this is a video which essentially shows how bubbles along with cells and certain drug particles, which are purple in color, are traveling in a vessel. Now, this is an focused ultrasound insonification that is happening in this region. And what you see here is that under this insonification, the bubbles are expanding and contracting, causing the tight junctions between the cells to open up and deliver the drug particles outside. And this is the mechanism that is being used for delivering any kind of therapeutic agents, be it chemotherapeutic agents or other molecular agents. Now, this is one study which did a blood-brain barrier opening in female mice. And this is a very visual representation of how they did the BBB opening on the on the right-hand side here, and it was evidently shown by Evans blue dye. Again, we also can use PET imaging, MRI imaging to look at BBB opening. This is another example from another study where they have captured the transient BBB or blood-brain barrier opening over time. Now, this blood-brain barrier opening that happens is not only useful for delivering a lot of drugs, whatever drugs that you want. However, it also has some downstream effects. So, for example, it can cause an increase in the range of inflammatory cytokines. It can also initiate glial clearance mechanisms. In the case of Alzheimer's, it initiates amyloid beta clearance. So there are a lot of downstream effects also that are being looked into. One thing to be cautious when trying out blood-brain barrier opening is that there is no standard model right now to use it. The range of parameters that one needs to use depends on what kind of condition you're treating, what part of the brain you're targeting, and what kind of bubbles you are using. So it's right now, it's an open area of research where people are trying to come up with a standard model. However, what I think will happen is that every condition will probably have its own standardized parameters. And with this, these are few of the conditions that are being treated just by using the blood-brain barrier opening mechanism. Now, so this is one effect that we can create with using bubbles and ultrasound. There is this second category of effect that we use, which is called inertial cavitation. Now here, what we do is we amp up the pressure of ultrasound such that these bubbles are not only just stably, periodically oscillating, but they grow bigger and bigger and ultimately collapse. If the pressures are high enough, we can even nucleate gas pockets that are present in a fluid medium naturally and create bubbles out of that. We don't need external bubbles in that case. So, one of such extreme conditions is called histotrypsy. Now, in histotrypsy, we use extremely high pressures. Now, to give you an idea, we all live under 1 bar of pressure. Now, you can imagine 30 elephants sitting on top of you. That is the amount of pressure we need to generate and create bubbles which grow bigger and then collapse. So, I don't know why. So, a video of this effect is shown here. Here you have these ultrasound high pressure waves, almost in the shock conditions, traveling from left to right. And in the focal region where the energy is highly concentrated, you'll see a lot of bubbles being nucleated, expanding and collapsing. And this is what we call a bubble cloud. This bubble cloud is powerful enough to destroy many things. One example is shown here. This is just a tissue where your bubble cloud has literally created a hole inside it. And this bubble cloud can target many different types of tissues, not just in the brain, but any nerve, eye, muscle, fat, heart, liver, you name it. In fact, this strategy is now FDA approved for treating liver cancer. So, one thing before I go a little bit more detail into this strategy is that any kind of treatment that we do, we need a lot of image guidance to do that. So anything that is to deal with bubbles, either stable cavitation or histotrypsy kind of cavitation, we have tried to leverage the bubble activity itself to be able to image it. What that means is that when a bubble is either oscillating or blowing apart, it releases these pressure waves that can be captured by an imaging array. And when you can capture these pressure waves, you can first look at the frequency spectra of the bubble behavior and identify what kind of activity it is. So in the spectra at lower pressures, you will only see certain frequencies extremely high. These frequencies are harmonic frequencies, and we can easily say by looking at the spectra that, okay, here there is stable cavitation going on. If I go high up in the spectra at higher pressures, a lot of broadband noise starts coming in, and that is our indication for, okay, now there is inertial cavitation or histotrypsy kind of cavitation happening here. In addition to that, we can also calculate the energy from these pressure waves and create this heat map to tell us what is the mechanical activity or the mechanical power in these bubbles to destroy something, as well as get the location of the maximum bubble activity. This all imaging usually happens in real time, and that is why we are able to look how, if we are doing stable cavitation or inertial cavitation, we can pinpoint where that activity is happening the max. We can direct and control it and get some feedback information out of it. Okay. So now a little bit into both of these mechanical stable cavitation and inertial cavitation. I will dive a little bit into some of the research that I have done with it so far, but there are so many different applications that one can explore. So in our past work, we have used histotrypsy for thrombolysis, who are very well aware here as to the condition of thrombus formation. It can happen anywhere in the body, stroke in the brain, blocking of arteries in the heart, blocking of veins in the leg, anything. And the usual standard of treatment is to put a catheter in the clot, deliver some drug, and hope to dissolve it over time. And this strategy works very well with acute clots. However, when the clots turn chronic, it is not exactly very easy to target or dissolve these clots, particularly because there is, I don't know what's happening, particularly because there is dense fibrin formation in these clots. And because of that, the clots become more intact and densely packed in its structure, and it's hard to dissolve it over time because the drug cannot penetrate into these clots. So the idea here was that we need to find some strategy that can help in the drug penetration, in making better the drug penetration throughout the clot. And this is where we turn towards histotrypsy. Histotrypsy uses, like I said, these high amplitude, almost shock waves. And under these shock waves, any gas pocket that is in a liquid, it will expand to hundreds of micrometers, in fact, in its size and create a bubble. As this bubble expands, it will create strain in the surrounding cell and tissue. Because of this strain, and the rate of creating the strain is in a matter of microseconds. So large strain created in a very short amount of time leads to rupture of the cells around the bubbles. And this is the strategy of histotrypsy that we use for clots. Our goal was not only to disintegrate the red blood cells, but also use the fluid mixing effects of the bubble activity that happen here to enhance the drug distribution inside the clot. Just a quick proof as to, Before that, I just want to show a brief in vitro experimental setup for parameter optimization that we use. And this can be extended not only to clots, but to any other kind of tissue as well. Our usual setups are like, we have a tank of water, we have a histotripsy transducer that is insonifying a tissue, in this case a clot. We have our imaging array to get the feedback of the bubble activity, and then we look at the metrics of then we look at the metrics that we are trying to see how if the treatment is successful or not. This is the feedback of imaging. Again, the heat map that you see inside this model vessel, which will help us to guide our histotripsy bubble cloud throughout the plot. And in the case of plot, we also use metrics like clot mass loss and histology to see if the treatment has been successful or not. A quick proof here is, this is a histological image of a cross-section of a clot. One is treated with drug, one is treated alone with histotripsy, and one is treated with a combination of both. And what we saw was that there is more mass loss happening in this case, which is statistically significant. More on the quantitative data side, here we have plotted mass loss with different lytic or drug concentrations, and we have treated only with drug in the blue bars, and in the orange bars we have both drug and histotripsy. And most of the time what we see is that the combination therapy works much better as compared to the drug alone. This is an example of one study which did the same thing that I'm talking with histotripsy and a blood clot, but in a porcine hemorrhage model. Here they created a cranial window to insonify a clot that they created in the brain. And here are some of the images that show how the treatment was successful. Here, this is the histological and the ultrasound image of the untreated clot. Here is the image of the treated clot of the histotripsy, but here they did not drain anything. So what happens usually with histotripsy is that if you're insonifying any tissue, any clot, it becomes liquid. It loses its structure. It becomes liquid. Now you need to drain that liquid or liquefied structure out of the vessel to prevent any further downstream effects. So here what they did was they drained the clot after it became a liquid, and here they were able to see later on after the study no rethrombosis or no dysfunctions in the brain. Everything was okay. Further on in this, we can also use some external nuclei to initiate histotripsy, but at the same time deliver the drug locally. So till now, what we are doing is we have been looking at histotripsy and systemic delivery of drugs. But there are these structures, things like the contrast agent I showed you, but a little bit more complicated, where you have a lipid bilayer shell. Inside it, you can have drugs encoded and some gas bubbles, which can initiate histotripsy later on. And the idea behind these such structures is that you can infuse them in a blood vessel. Once they reach the clot location, they will come in contact with the histotripsy bubble cloud. The lipid shell will break, release the drug, and the gas nuclei which are inside these structures, they can help initiate, or they can help extend the bubble cloud activity further. As an example of what it does, so here is a model vessel which is filled with such structures, the shell structures that I just showed you. And what we are doing is we are increasing the pressure from the source, the pulse pressure that we are applying from the source. And as the pressure increases, we start seeing more and more bubble activity as represented by this heat map. If we wanted to quantify it, we typically take a pixel value of the highest activity that is happening in this heat map, and we plot it with the pressure. So here is kind of a pixel value of the mechanical energy in this heat map, and this is plotted against different pressures. We are looking at two treatment arms. One is where there is no external nuclei, so histotrypsy is being created from the nuclei which are inherently present in a liquid. And on top here is the medium where we have introduced these bubble nuclei, these shells that you just saw. And one evident thing that we started noticing here is that the histotrypsy bubble cloud without any external nuclei usually starts happening at 23 megapascal. However, if you add these external nuclei, it will initiate at lower pressures, which means that it can be safer for the surrounding medium. Moreover, it also creates more bubble activity. It increases the bubble activity, so that means there will be more ablative power with this kind of histotrypsy bubble cloud made from external nuclei. Okay, so with this, some of the, I can probably go into the next slide. Yes, some of the key takeaways with this, particularly with the histotrypsy and its interaction with tissues, particularly blood clots, was that most of the time histotrypsy works extremely well when there is synergistic effect between the drug and the bubble activity. And if you introduce any external nuclei, especially for localized drug delivery, you can expect to see some changes in the behavior of that bubble activity. Maybe it is advantageous, such as we saw in this case, where your activity increases and initiates at lower pressures. Now, very briefly, I wanted to also touch upon some of the things where histotrypsy may not be possible to use. Maybe there are some external sensitive environments where you don't want to ablate things necessarily. Or one of the examples is fibrotic tissues, where histotrypsy has been partially successful, but not overall. Nobody has tried in the brain, so I'm just picking up examples for other kind of tumors, pancreatic, prostate. People have tried to use histotrypsy even with longer pulses, but either it results in the risk of creating heating effects, or the ablation is not exactly very, very complete. And there is a reason behind this. The reason behind this is shown in this picture here. What happens is, so here we are looking at a bubble in the histotrypsy bubble cloud with increasing frequency and with increasing stiffness of the tissue. The more important thing to look here is the first row. So if you see, as I keep on increasing the medium stiffness, my bubble that is growing in that tissue becomes less and less. A more quantitative picture is shown here by the study, where what they did is they looked at the radius of the bubble and its evolution over time in different mediums of different stiffness. What you see is that the bubble is growing less in a stiffer medium, as well as it is only growing for very shorter times. What this boils down to is that its ablative power relies on how much it can expand, and that ablative power reduces in stiffer tissues. This will be also very true for these kind of networks, and I'll tell you why I focused on it, because this is also my research area. But if you are dealing with tissues that are heavy in fibrin and collagen, you will see the same kind of results, because they are also highly strain stiffening tissues, which means that the stress in them increases with the strain. So just to give you a very brief overview, my research is also a little bit into how to treat fibrotic environments. And here, what we are trying to develop is a mechanics-informed cavitation, where we are using the similar kind of periodic oscillation of bubbles, but now they are informed by the properties of the material. How do we do that? So this is, I don't know if this fluorescent image is much visible in the light, but here this is an example of a collagen or a fibrin mesh, and we have increased the density of the fibers in this. While we increase the density, the stiffness increases and the pore size decreases. If the pore size decreases, you can expect that the drug penetration will also be low. Such stiff environments or collagen or fibrin mesh exist in clots. They exist in the ECM of many cancers. So this is how its relevance come into picture. And what we do is we first characterize the stiffness of these materials, as well as its some plastic properties. So when these materials are close to fracture, they show interesting mechanical properties. They are able to extend a lot, so they resist fracture. They are able to absorb a lot of energy before fracturing. So these are some of the properties that come into play, where you can, if you know how to tune them, you can probably tune your acoustic parameters also to make the treatment better. And this is what we are doing. We are taking these properties of the material, particularly since we want to fracture them, so properties close to the fracture, we understand this effect, and then we inform our acoustic parameters to play in the regime where we can induce fracture in the material. One of the examples is shown here. This is an in vitro study done. Here, what you see is a fluid medium, and on the right-hand side is a mesh of fibrin or collagen. We are putting ultrasound from left to right. In this fluid medium are bubbles floating. And what you will see in each of these videos is that the bubbles with increasing pressure are able to penetrate this dense fiber mesh. This fiber mesh has a pore size right now of less than 1 micrometer and a stiffness of 3 to 4 kilopascal. So this is the kind of mesh we are usually dealing with, and what we see is that as we increase the pressure, the bubbles are able to penetrate more and with higher speeds. What it means essentially is shown in these videos here. I don't know if they are playing. So what we did here is we used nanoparticles, fluorescent nanoparticles as drug markers. These are around 200 nanometers in size. And what we wanted to see is if these nanoparticles, which are a drug marker, will they penetrate into this fiber mesh if the bubbles are penetrating? And this will help us to claim that probably this strategy can help in increasing the drug penetration, which usually is inhibited by such fiber meshes. And we again see the same thing, that at the focus region where most of the penetration is happening, the drug particles or the nanoparticles are able to penetrate up to 200 micrometers in depth, while away from the focus, there is not much penetration happening. Again, for the last slide, I also wanted to show what it meant mechanically for the tissue. While these bubbles were able to create an enhanced drug penetration, they were also able to introduce some kind of material softening in the tissue. And this is an evidence of the modulus decrease that happened with increasing pressure that I put on the bubbles. So this is my last slide. And to summarize, what we saw with histotrypsy was the fact that you can use it to ablate tissues, you can increase the synergy of drug and histotrypsy to make your treatment better. You can also introduce some extrinsic nuclei to increase that activity. And some of the times, we may want to move away from histotrypsy or maybe use a combination of histotrypsy and some other kind of strategy, particularly we are dealing with very fibrotic tissues. Okay, so with this, I would like to thank everybody for being patient and listening to this 40-minute talk. If you have any questions, please let me know. Yeah.
Could you say a little bit about bleeding?
So yes.
Say like in liver.
So bleeding is so this histotrypsy is very fascinating in this manner that for most, I would stay away from the brain because they have observed a little bit of bleeding. I would not say that it was completely at the intensity where the animal died, but usually in any other kind of tissue, hardly any bleeding effects observed. And this is because of the fact that histotrypsy acts almost like a surgical knife. The boundaries of ablation are just so precise that the vessel sparring, and there are evidence of histological images of vessels where there is no evidence of any scarring or bleeding in the vessel.
I'm going to kind of dovetail on that question. Would it be possible to use both a mechanical histotrypsy methodology plus heat generating methodology to coagulate at the same time, so you could do a treatment and coagulate around the treatment borders?
Possibly, because we have something called boiling histotrypsy as well. Boiling histotrypsy actually works in an opposite manner. It tries to heat up the things first and then use that heat conditioned environment to generate bubble activity. In cases where bubble activity alone is not doing the job, for example, in fibrotic tissues. But if I wanted to do reverse, yes, you can do it. You may need to use different acoustic parameters to be able to do that. Let's say first destroy the clot, and then after a while, when you think it's safe, use some heating, heat that area to coagulate. But it has not been done so far.
Well, I will just make my commentary here. When I went to your guys' global meeting on therapeutic ultrasound, basically every single person there every scientist there was interested in this and working on some component of it. What struck me was that there were a handful of neurosurgeons there, which was quite interesting, but it was like a million years ago when neurosurgery first started, we adopted the Bovie, which was electrocautery, and this was like maximize Bovie's. Scientists and engineers working on all these problems, and so it's just up to us to kind of talk to you about what we would like to do with it. That essentially, bleeding's an issue. We typically just coagulate it, so that perhaps you would coagulate a rim first, then treat the core. There's many different methodologies that we would think of using just because of what we do normally day to day.
Yeah. And this is something that, particularly like in the hemorrhage model that they tried, they observed, again, there probably are ways that we can optimize it better. Right now, it was just, I think for that study, it was just first of all to ensure survival with this technique. And indeed, it was successful in doing that. But yes, in order to prevent bleeding and all, we need to probably optimize the parameters better and have more interactions with people who know the brain better. Yes.
So there have been some recently high in the press human demonstrations of transiently opening the blood-brain barrier, PSI, et cetera.
Yeah.
I'm just curious in terms of potential interactions with things like amyloid angiopathy. So, whether you have a stiffening of the artery, do we know well how this will work in kind of different vessels under different conditions and how transient the blood-brain barrier opening will be versus if you have someone with severe amyloid load and angiopathy, do we know it'll behave the same?
We don't. So this is a very good question, and we don't know. And that is why, that is why I mentioned particularly the fact that right now, well, they have achieved blood-brain barrier opening and they have demonstrated it in some cases, but how it varies from vessel to vessel is an open area right now. How it varies with different conditions, even the degree of a certain condition. For example, in Alzheimer's, they showed that there is some sort of amyloid beta clearance, but at what degree was that condition already developed? Don't know. How it will behave in extreme high load of amyloid beta? Don't know. So this is an extremely open field to play right now.
I have one more
Yeah.
question. Have you tried for the fibrous tissues to inject some of the liposome to see if that amplifies the treatment effect?
I have not. And it can be something to try, particularly if they are like fibrin targeting or collagen targeting drugs that can help to, precondition it so that the bubble activity increases. I think for treating fibrotic conditions, it's all about how we precondition the environment so that our bubble activity can increase. One of the ways I showed was here, but there are probably other ways, either heating it or delivering some drugs somehow to be able to precondition that environment. It is totally possible. I've not tried it though.
Could the ultrasound be delivered through a catheter?
Yeah. So there are already, and this is where the commercial players come in. So there are already these people, I think from GE particularly, and some other new startups right now who are developing catheters with a histotrypsy transducer at the front, but it is in the development stages.
The FDA has a lot of concerns about typically you're running 120 volts or something like that to actually cause the
Exactly.
piezoelectric effect. And if you stick that in and then something goes wrong, you have a single fault tolerance problem. That's been the problem historically.
Yeah, so they are still in the development phases. I mean, they have developed something like there was recently an endoscope with a histotrypsy transducer in it for treating pancreatic, but this is all in the research phase.
Henry, you're not vaccine? No questions.
Oh.
All right. Thank you very much. We really appreciate it. Thank you.
Get down.